Welcome everybody, and thank you for joining us today for our Meet the Coroner in Court. This is specifically looking at leg ulcers. My name's Sam Wharton and I'm a tissue viability nurse advisor for Coloplast, and I'm joined today by Janice Bianchi, who is also a tissue viability nurse advisor for Coloplast, who will be also doing some of the session this morning. And I've also got another colleague, Charlie Pick, who's a tissue viability nurse advisor for Coloplast. Janice and Charlie will be supporting any questions you may have, so please use that chat function if you have any questions or observations that you'd like to add in there, and they will happily support that. Please ask any questions as it goes on within that chat function, and there are little breaks in between the sessions that we can discuss anything that you've brought up. So we've got sort of three separate parts of this webinar this morning. So the first part's going to be looking at the importance of documentation. On the first day of training, we're always told if you didn't write it, it didn't happen. So it's really looking at why we need to make sure that our documentation is as accurate as can be to provide that evidence if, unfortunately, if anyone is called to the coroner's court. Then we'll be doing this section looking at solutions and pathways for managing patients with venous leg ulcers. And then the last section of today's webinar will be the actual Meet the Coroner in Court, which will be facilitated using videos, and there'll be breaks and opportunities for discussions throughout that. So without further ado, I shall start with sorry, IT is not my forte. I haven't got anything here. Is it all okay? Yeah. Sorry, gotta love IT. So this morning we're going to be looking at the importance of your documentation. It helps to make sure that your documentation is as good as it can be to benefit you, your practice, and to benefit the care of those patients that you're looking after. It provides that evidence of care and treatment that you've given. So it is a fundamental part of your role as a clinician to ensure that your documentation is as good as can be. So as we're having a focus for leg ulcers on today's Coroner's Court, we're just going to have a bit of an overview about leg ulcers. So NICE defines a leg ulcer as a break in the skin below the knee, which has not healed within 2 weeks. So for myself, when I was practicing, I would often have patients referred to my clinic and they had had a wound that was caused by maybe a trauma, a cat scratch on their lower leg, and it was still referred to as a traumatic wound. And they may have had that open break in their skin for months. So it's really important that we actually identify that if there's a break in the skin which hasn't healed within 2 weeks, we need to be managing it as a leg ulcer and doing all that care, full holistic assessment to make sure we're treating that underlying disease and provide that appropriate wound and skin management and compression where it's indicated. And it's also ensuring that it is that strong compression therapy, as that will be the key to reduce time to healing and reduce those risks of further complications. There's also a very, very large financial cost of venous leg ulcers. You know, some of those figures there, the average of £7,600 per patient with a venous leg ulcer. And if you think of your patients that have had their venous leg ulcers for years, you know, that cost is going to be mounting up on a yearly rate, up to sort of £14,000 for unhealed venous leg ulcers. So there is a real burden to the NHS in terms of that monetary impact. It's obviously, there's a lot of variation across the UK. We've had the National Wound Care Strategy set up with their recommendations to try and reduce some of that variation, because that will itself cause increase in costs of care and extended healing times if patients aren't receiving the most appropriate care, gold standard care for their ulcers. We know that there's a very high reoccurrence rate of venous leg ulcers, with only half of people healing within 12 months. So when you're thinking of your patients that have had a wound for 12 plus months and the impact on their actual quality of life, we need to be healing these patients to make sure that that impact is reduced and minimized as much as possible. There's also studies which show that there's up to a 70% reoccurrence in patients that are not fitted with compression hosiery following healing. So again, it's having those open conversations with your patients and giving them that understanding of actually this is venous disease and it's a long-term management throughout the rest of your life. It's not once this wound's healed, you can then remove that compression, because what will happen is that edema will just come back, and any sort of break in the skin again will just result in further ulceration. So it's really being open, transparent, giving that patient the informed information so that they understand the importance of why they need to continue wearing that compression. And this is a really good example of how to illustrate what happens if we don't get it right against what can happen when we do get it right. So this is Betty's story. I don't know if some of you on here might be familiar about Betty's story. So this was an NHS Right Care project that was done back in 2017. And it gives you these two pathways. So Betty is a 70-year-old lady. She's slightly overweight and it's identified on her health check. But there's no sort of further investigation or support for her at that point. At 74, she grazes her ankle and she sort of self-manages, puts a plaster on. After 5 weeks, it hasn't healed, so she decides to see the GP and she gets antibiotics. After 2 weeks, the antibiotics haven't worked, so she goes on to see the practice nurse, who then prescribes further antibiotics and an antimicrobial dressing. They continue this treatment for 6 weeks. Her visits are increased to 3 times a week. The wound's not healing. Another antimicrobial is tried, that doesn't work. So she's then referred to the vascular team. 8 weeks after that referral, she sees the practice nurse and has to wait another 5 weeks until her notes arrive for her to get that appropriate treatment. In the meantime, her conditions become worse, her mobility is reduced, and she's then having to be seen by community nurses. When the community nurses go in, they request an ABPI, and a full assessment is completed after a further 7 weeks. Unfortunately, she can't tolerate the compression at this point because her pain levels are high, the wounds have deteriorated, and she ends up getting a cellulitis, and she's then admitted to hospital for 5 days. After various treatments and compression therapy, Betty eventually heals after 2 years. And you can see that that's a really sad situation for poor Betty. And when you look at the cost, you know, that's over £5,500 in NHS costs just to get her healed after 2 years. So obviously this is the pathway we don't want our patients to be going in. And unfortunately, we still see a large majority of patients that are getting that suboptimal pathway. And then we've got our optimal pathway. So this is where we want the patient to be seeing the right clinician at the right time and getting that right treatment. So this is your sort of optimal. At 70, Betty is given compression hosiery. When she goes for her health check, she then grazes her ankle at 74 and visits the pharmacy. They follow the lower leg pathway. She's seen by the practice nurse and 2 days later has a full assessment and ABPI. After 5 weeks of treatment, the ulcer is healed. Betty continues to wear her compression hosiery with an annual lower limb assessment, and she's healed within 6 weeks. And that's at a cost of £500. So you can see that those real extremes of the care that Betty's had. And we obviously, like I say, it's about seeing the right clinician at the right time and getting that right treatment. And the outcomes can be so different for a patient. When you think of actually the impact on Betty's quality of life within those two pathways, I don't think any of us sat here would want any of our family or ourselves to go through that suboptimal pathway. And we shouldn't be going through that suboptimal pathway. We should all be getting that optimal pathway. Talking again about the patient impact. So venous leg ulcers have a significant impact on that patient's quality of life. It impacts them personally, social, and also those psychological effects. If you've got a wound for a long period of time, there's lots of evidence out there that show that there's a high proportion of patients that have long-standing wounds that have depression. Some often feel socially isolated. If that wound's quite odorous, they don't want to see patients. They don't want to see their family. I had a patient that I saw in clinic who his only mode of transport was getting on the bus. And due to the odour, he was too self-conscious, and he'd had some comments when he was on the bus and people moving. So then he lost his only mode of transport. So he had to then get taxis to the clinic. And again, that's more of a financial burden on the patient. There are lots more younger people with complex wounds and lower limb ulceration. So then when you're thinking of that financial burden, when you're thinking if they're of working age, are they having to take repeated time off? Is that having an impact on their work? Are they having to take a pay cut because of the hours they're missing? How is that affecting their relationships with other people at work? Do they, if they don't fully understand, do they resent that every afternoon Mr. Bloggs gets to go and leave work, and then that they're having to pick up that work? So there's a lot of financial burden. Also, when you're thinking about leaking legs and that volume of exudate you might have, the burden on changing bed linen, on carpets. I've been to patients' houses out in community where the carpets are sodden with exudate, and that's going to place a financial burden because that is going to end up smelling, and things will need to be replaced. Pain is another real significant factor, and is often underestimated. And often we have sort of these discussions saying, Mrs. X is non-concordant, when actually, have we addressed her pain? Have we looked at her analgesia needs? Lots more of our elderly patients, they don't like taking painkillers, and it's having that time to have the conversation so that they understand they need to regularly take pain medication, which will then be able to help them to tolerate the compression, because sometimes when compression first goes on, it can be slightly more painful, but actually it's been shown that once they continue with it, that pain will reduce. So ensuring that accurate assessment is really, really crucial in ensuring that patient gets the right treatment, and we reduce that impact for the patient. Leg ulcers can or may also lead to severe disability, such as an amputation. This would be seen more commonly with your patients with sort of that peripheral vascular disease, ischemia, diabetes. And you can imagine that impact that will happen to that patient if they end up with an amputation. That's a complete sort of lifestyle change, and will need lots of adaptations for them for the rest of their lives. They also require extended hospital stays. They may result in infection and osteomyelitis. They can be life-threatening. Patients can get sepsis from their leg ulcers if they're not managed, and those early signs of infection aren't picked up on. And they may result in the need for surgery or prolonged periods of forced immobility, where patients have literally got to put their legs up because they just pour if they put them dependently on the floor. So again, there's a whole multitude of impacts on those patients, which is why it's so important that we get it right that first time for them. So I did allude earlier slightly to the National Wound Care Strategy recommendations, and this is just sort of the key elements that have been pulled out from these recommendations. And for leg ulcer wounds, that first line, mild graduated compression of 20 millimeters of mercury can be applied if there's no red flag. So this is a really sort of new concept and a new idea, but it's ensuring that those patients are getting adequate compression from the start. Obviously, if any of those red flags are apparent, then you would not apply the compression, and you would either refer on or get further support for those patients. So your red flags are sort of acute infection of the leg or foot, symptoms of sepsis, that acute or chronic limb threatening ischemia, suspected deep vein thrombosis. That's not to say that once the treatment's actually in place, so if they're having that anticoagulant therapy and their pain is manageable, you can then do an assessment to see if they are able to have compression. But again, wait till they've had that therapy and anticoagulant medication is on board. And also if you've got suspected skin cancer. So if none of those red flags are apparent, then you can go straight to that 20 millimeters of mercury compression. That can be achieved either with, so some of the liners are 10 millimeters, so you can put two liners on. There's bandaging systems that can give that reduced compression. So be aware of what's available to you within your formularies and how you would achieve that 20 millimeters for that sort of first assessment. After that first application of that 20 millimeters of mercury, within 14 days, that patient should have a full assessment, including an ABPI. And if able, they should then go into that strong compression. And that's really important. And I think my observation is that we sometimes get to that reduced compression, but actually getting it up to that strong compression is sometimes delayed, and where we really need to be tightening up those times and making sure that we're dealing with it and getting those patients in that right strong compression, that therapeutic compression, as soon as possible. Also, another new addition is that patients with adequate arterial supply should also be referred to the vascular team, because they may be able to have some venous surgery or ablation, endovenous interventions that can improve that circulation. Obviously, I don't know what the waiting times are within your area, so it might be interesting to find that out. But it is part of those recommendations that patients are referred on to vascular. Continue monitoring once you've got that strong compression on, and if there's been no significant progress or that wound's deteriorating within 4 weeks, it needs to be escalated. You also need to go back to your initial assessment, because maybe something's been missed off. Have you optimized that patient as much as possible in terms of their nutrition, management of long-term conditions? If they've got diabetes, what are the blood sugars doing? So there may be something that's been missed. So yeah, if within 4 weeks there hasn't been significant progress, then it is really important that that patient's escalated, not sort of sat on and just continued with for months and months and months, because as we know, the longer a wound's present, the more chronic it becomes and harder to heal. Now we're moving on more onto the sort of the reporting framework. So we used to do incident reporting, but now I don't know if it's across the whole of the UK yet, but I think by the middle of this year, all trusts should be using this PSIRF, or Patient Safety Incident Reporting Framework. So you would use your initial reporting system. So I think mostly Datex is used. So it's making sure that you've reported that on your clinical reporting system. Then the incident's verified by a clinician deemed appropriately trained. So that could be your sort of locality managers, case managers, ward sisters. So they will just review the incident. And it's about removing that sort of blame culture and making it a much more cohesive environment for people to learn. So this is where that compassionate engagement and involvement of those affected by that patient safety incident. So getting all the colleagues that are involved to be involved in that investigation, to make sure that they feel like their voice has been heard and they can learn those lessons themselves. being a TVN for many years, we did lots of incidents, primarily around pressure ulcers, and often the clinicians that were face to face and actually giving the care to those patients weren't involved in the incident reporting, so therefore didn't understand or get a grasp of that learning that is so rich that comes out of investigations. So I think this is a much nicer way to involve everybody. It's also being open and communicating with the patients. So a bit later on, we'll be talking about duty of candour, but it's just having that open and honest conversation with families and carers and patients when things haven't gone as they should have done. Application of a range of system-based approaches. So again, it's just ensuring that learning is shared across the whole trust, so that then you're mitigating that risk that this could happen again, and considerate and proportionate responses to patient safety incidents. So again, it's moving away from that blame culture and making sure that the outcome is proportionate to the harm that was caused. It also now includes that supportive oversight, and again, it's about ensuring that the response and the system functionings facilitate that improvement rather than that blame. So it's all about improving communication and lessons learned across the whole of a system, involving all of those people that need to be involved, and creating that sort of response, that plan, that action plan moving forward, and making sure that it's visible for everyone to be involved. So if you are called, or if these are just possible consequences, if something happens to a patient under your care, and this isn't to scare everybody, it's not to make you think that next week you're going to be called into coroner's court or the NMC for a fitness to practice, but we are looking after patients, we are looking after people, and sometimes things do go wrong and there is human error, and these are some of the possible consequences that may happen. So you may be called for a disciplinary or capability hearing, the coroner's inquest, which obviously we'll be delving more into with the Meet the Coroner in Court shortly. You may be called to magistrates or Crown Court. There may be a public inquiry. You may be called to the Court of Protection, civil claim or negligence. There may be employment tribunals and the NMC fitness to practice. And then you may have that defensible, non-defensible nursing practice hearings. So there's many different consequences that could happen if an incident happens with one of your patients. We're all professionals, we're all accountable for what we do, and we're accountable for our actions and our omissions in our practice. So for those of you that are qualified, you'll be sitting on the NMC register, and we have our own code of conduct, and we need to be able to rationalise and give evidence as to the choices and the actions we do with our patients. As nurses, we make a wide variety of oh God, what's the word? We make lots of choices for our patients. We act in their best interest, and we're using our professional knowledge and our skills to make that decision. But we need to be able to evidence that and rationalise that. And if you've had conversations with your peers or with other colleagues to come up with that decision, it all needs to be documented, because we need to be able to justify those decisions and why we've made them. And that's why our documentation is so important, because it supports the decisions that we've made. As a tissue viability nurse, I would sometimes do things that maybe weren't the norm, but I had that clinical understanding, knowledge, and the rationale for why I would do what I would do. And I would always follow it up with very, very close monitoring and reassessment, so that then if I was called or something ever went wrong, I had my rationale, my justification for what I decided to do with that patient. So coming back to professional duty of candour, so it's all about being open and honest with our patients when things go wrong. It's a legal duty that we have to do it. It's about telling the person when something's gone wrong, and it's also about apologising to the person. So when this first came out, there was quite a lot of fear within clinicians, that they felt like if they apologised, that then they would be blamed for everything and they could be sued. But actually, it's just saying, you know, something's happened. We're sorry. We're going to investigate it. We are going to keep everything as open and honest with you. And moving forward, we'll keep those lines of communication open. And actually, in my experience, it's reduced the amount of complaints and concerns from family and carers, because you've had those open lines of conversation and communication. And you need to fully explain what's happened to the person and what those short and long-term effects of what's happened to them is going to be. So I see it as a really positive move forward. And like I say, where I was working, we saw a reduction in complaints because people were having those conversations as soon as possible with the family, to really reassure them of what's happening moving forward. So what is the role of the coroner? So the coroner's jurisdiction is limited to determining who the deceased was, how, when, and where they came by their death. So who the deceased was and where they came to their death, and when's quite easy, but it's the how. So this will be the main focus for coroners' courts. It's about how that patient came to their death. The coroner will decide whether to hold a post-mortem examination, and they will decide if an inquest is needed. So that's what the role of the coroner is. So you get pre-inquest hearing and a coroner's inquest. So pre-inquest hearing, if a full inquest can't be held within days of the death, this will be an open to the inquest, a short hearing called a pre-inquest hearing. And at that point, the coroner will decide how long the inquest is likely to last and whether a jury would be needed. So that's what that sort of pre-inquest hearing is. Very short, not necessarily held in public, but it's just that quick initial, what do we need for this case? And then you've got your coroner's inquest. So this is a legal inquiry into a death. And it's when the cause is unknown, violent, or unnatural. The coroner's inquest is held in public, and the coroner determines the cause of death, and it's usually held without a jury. So you are able to go to coroner's inquests if you get the opportunity. You can just go on to your local council website, and they usually have a list of coroners' courts that are occurring. And like I say, because they're mostly held in public, you're able to go and attend. In some circumstances you won't, so if it's involving children or there's sort of a public reason that you can't attend, then you won't be able to. So it's just letting you know that. So what is your role in the coroner's inquest? So it's a legal requirement that you attend. It's not a if I can be bothered, or if I want to. It's an absolute legal requirement that if you are called to go to coroner's court, you need to attend. You're expected to answer their questions as accurately as possible, and you do it under oath. It's not there to apportion the blame. Like we said before, it's about finding how that patient's death occurred. And you need to be able to lean on your records to be able to document and evidence what you did within that case. So some coroner's inquests can be called years after the actual care was given. I know for myself, by the time I sleep tonight, I'll have forgotten today. So there's no way I'm going to remember what I did with a patient a year ago. And all I will have to support me is whatever I've written in my documentation. So, you know, today's about really asking yourself, is your documentation good enough? If you were called into coroner's court in 2 years' time, would you know your rationale for giving the care that you gave to that patient in 2 years' time with the documentation that you're providing? And if you're thinking maybe not, then really have a think on how you can improve your documentation to make sure that you're ever in a situation where you need to provide that evidence, that you've got that documentation to support you. You should only state facts when giving your evidence. It's all right to say you don't know. Don't try and sort of make it up and think, well, I'm sure this is what I would most probably thinking when I did this, because, you know, going back to what I said on that first day as a student nurse, if it didn't write it, it didn't happen. So like I say, you're right to say you don't know. So these are the facts or verdicts that the coroner can end up with after listening to an inquest. So some of these are quite self-explanatory. So natural causes, a normal development of a natural illness, not significantly contributed to by human intervention. Like I say, quite self-explanatory. Then you've got your sort of accidental death or misadventure. So that's where the death was unnatural but not unlawful. So the deceased has taken a deliberate action that has resulted in their death. So an example of this could be in the summertime, lots of children like to go swimming in rivers. And on the news, you heard of, unfortunately, them being taken away by the tide. So this was it was an unnatural death, but it was not unlawful. Also, it's a lot colder at the moment, so people that have gone onto frozen lakes and then the ice has cracked and they've gone into that ice water and unfortunately have died. Again, that's another example of that unnatural but not unlawful accidental death or misadventure. Unlawful killing, so murder, manslaughter and serious driving offences. Suicide, where the deceased voluntarily acted to end their life in a conscious way. Neglect, so this is maybe where some of the nursing related inquests may end up with a verdict of neglect. So that's that gross failure to provide the deceased with the basic needs. And then a narrative. So this is where the coroner sets out the circumstances of the death in a detailed way based on the evidence heard. So those are the facts and verdicts that can end up after your inquest. And there's also this Regulation 28. So this is where after an inquest, the coroner can write a prevention of future death or Regulation 28 report. So if the coroner feels that the evidence they've heard will not stop further deaths, then he can action this Regulation 28. And the report is sent to the person in authority, and they have to make those changes that are suggested, and they have 56 days to respond and show all the changes that they've made according to the coroner's recommendations. So I actually Googled and did a search to see if there were any Regulation 28 that I could find relating to leg ulcers, and I actually found one. And it was a patient that had, sorry, I'm just trying to find it because I can't remember it all. Yeah. So it was regarding a patient who died from gangrene. So she had a trauma to her leg when she was out in community. The antibiotics weren't given, and then there was a delay in reporting and escalating that the antibiotics weren't given. Signs of sepsis were not picked up on, and eventually she was admitted into hospital. The leg wasn't salvable, so she ended up going onto a palliative pathway, and she died in hospital a couple of days later. So the coroner raised the Regulation 28, and his concerns were that there was no photos taken, there was no escalation to GP when the antibiotics were delayed, there was no escalation to the senior team, there were incomplete records, the records were brief, they had no detail, there was a delay in antibiotics due to poor records, the development of sepsis was missed, there was no care plans, and carers' medication charts were incompleted. And she also missed some visits. So there's a catalogue of issues that the coroner had raised here. So he will have written that into a report, and that community trust had 56 days to show how they were going to omit all that risk and what processes they put in to ensure that that wasn't moving forward a risk for any other patients within their care. So that's just a good example of a Regulation 28 relating to leg ulcers. So record keeping, it's part of our clinical governance that we ensure that we record everything. It's an integral part of the nursing and midwifery practice. It's not an essential, it's not an optional extra. It is something that we need to do to ensure that we're providing safe and effective care for our patients. Records include anything that makes reference to the care of the patient, and any record can be used as evidence or called as evidence as part of a serious investigation. And on the next slide, we'll be going through some of those sort of examples of what can be called upon as evidence. So it is really important to stress. I know, at the minute it's quite busy out there. Every service is pushed, overloaded with work, and you struggle to even get a drink. But even then, you still need to make sure your documentation is completed before the end of your shift or before you finish your clinic. Your documentation needs to be completed. If you're finding that you're having to work over your time consistently, then that needs to be raised either through your reporting system, so maybe completing Datexes, if you're not being given that provision of time to complete your documentation. But like I say, it's not an optional extra. It's not something you do if you've got time. This is a key element of your accountability and your duty as a professional working with patients to complete your documentation. So like I say, we're going to go through some of the different forms of records that can be called upon. So obviously paper records, I think most trusts are now mostly electronic, but there are some that are still using a combination of paper and electronic notes. So all of that would be called upon. Any emails relating to that patient and their care, or any emails to other professionals, maybe you're asking for support or advice. So all of those can be pulled on to be used. Handwritten clinical notes, letters to and from healthcare professionals, care plans, wound and risk assessment forms, any photographs. So most places now have the facilities to be able to photograph wounds, which obviously is very important in showing either deterioration or healing of wounds. Lab reports, x-rays, any telephone conversations. So when I was out in community, I always had a pad of paper next to me, because often you'd get calls while you were driving, and you'd pull over and just make notes on whatever conversation I'd had, because my memory isn't that great, because by the time I got back to base, I wouldn't have remembered that conversation. So again, just making little notes and making sure that that's recorded, those conversations you have with other healthcare professionals, as well as the patient or their family and carers, and also what medication that patient's using, and their prescription charts, etc. Like I've said a few times, if it didn't happen, if it's not recorded, it didn't happen. And I know I keep repeating this, but it's because it is so essential. Careful and accurate records may assist you if you're trying to defend claims of negligence, and that is what you will have to support you and to evidence what you've done in terms of your care for that patient. So some of the common problems that are seen when investigations are carried out, and I know when I was often involved in the investigations of pressure ulcer incidents, and these are very common themes that were seen throughout those. So that absence of clarity, not really sort of a bit of a wishy-washy overview, as opposed to that real clear definition of what's happened and your rationale for doing what you're doing. Failure to record action when a problem's identified. So if for example, you had a patient with pressure damage and you've identified that they've got an area of non-blanching erythema, but then you've documented that, but then you haven't actually documented any of the action that you've taken following that, because if you find someone with an area of non-blanching erythema, you're going to be doing other things. You're going to be looking at their equipment, you're going to be looking at the rest of their skin, You're going to be identifying any issues with their incontinence, looking at their nutrition and everything else that you would be doing, and you need to make sure that you've documented that. Failure to escalate, so that's clearly illustrated within that regulation 28. You know, the patient didn't have her antibiotics, but that wasn't escalated. That wasn't escalated to seniors to share that information. Again, with patients with leg ulcers, if there hasn't been any improvement within 4 weeks, we need to make sure we're escalating that and getting that patient to see the right people to identify what needs to happen to make sure that that leg ulcer's starting to heal. Missing information, so again, relating back to pressure ulcers, often on the Waterloo score, this was quite a common theme. That only one column of the Waterloo score was filled out. Another example could be on sort of wound charts where some of the information's recorded and then some's just sort of had a little dash put on it or just not recorded in there at all. Inaccurate wound measurements. Again, photographs really help with your evidencing what the wounds look like. But like I say, wound charts often are half completed or not accurately completed. And here we've got some examples of common issues found in patient records. So again, it's just not having that clarity. It's just not really understanding what's been written, because leaking plus or plus doesn't really tell me much, because your plus might be my plus. So, you know, we need to really make sure that our documentation is as clear as can be. Dressed as plan, what plan? Is there a care plan? Has the dressing gone as it's needed to go? Have you put on that compression? Ulcers deteriorated. We need more information than that. What size is it? Was it before? What size is it now? What type of tissue is there? Why is it deteriorated? Care given as plan. Again, very undetailed. We need more detail than that. Compression applied. What type of compression? How was it applied? Who applied it? Compression declined. Again, have you had that conversation? Have you fully informed that patient as to why they need that compression and then they've declined? Or did the patient just say, oh no, I don't want that on, and that was the end of the conversation? So you need to document the conversation that you've had with that patient, and always go back to it, because they may decline one day, but actually if you go back the next day, they're more than happy to have it. And we say this little thing about 3 little words. So again, it's just thinking about your documentation out there in practice and whether you need to add a few more words that will actually help you in the long run to make sure that your documentation can stand up if you were ever called to coroner's court. So instead of just a wound to leg, left medial malleolus. So straight away you've got that anatomical location. Antimicrobial applied. So why was that antimicrobial applied? To manage that bacterial burden. Skin vulnerable. But why is that skin vulnerable? Is it due to the moisture? Is it due to the dryness? Again, just thinking of those few extra words that you can add in that are going to make your documentation so much better. Reduced compression applied. Again, why? Because it's a mixed etiology. So again, just that extra information. Advised. So that really doesn't say much, but actually if you said discuss with patient relative carer, utilize the local patient leaflet, follow through the sections. Again, you're just showing all that extra information that you've given to that patient. Care given, leg dimensions reviewed. Care given, concerns discussed with, escalated to. Concerns discussed in handover. Refuse care, safeguarding considered, referral. See, it's just that extra bit of information that can really, really help. So that's my part of this webinar completed. So what I'm going to do now is I'm going to hand over to Janice for the next section, and then I'll be back support in between the videos to bring any of sort of the discussion forward. Okay, so at this point, I'm just going to hand over to Janice.
Thank you, Sam. And just before I start, so my name's Janice Bianchi. Sam introduced me, and I am tissue viability nurse advisor with Coloplast for Scotland and Ireland. But I also work a lot with leg ulcer education in Glasgow Caledonian University and other places. So leg ulcers are something which have been a big part of my life for a very long time. I just wanted to pick up on some of the questions in the chat. And Charlie, I know you were answering them, so well done you. But people have recognised that suboptimal care very often happens, that we are waiting for longer periods of time for Doppler ABPI to be carried out. And that's for different reasons. It's because in some cases people don't have the confidence or competence or the sheer volume of patients. So there are big challenges out there, and we're hearing that across the whole of the UK. So don't think in your area that we're really struggling and maybe it's better elsewhere. Everyone is struggling at the moment. But really, the National Wound Care Strategy Programme is a big step in the right direction of moving things forward. And we know that one of the things that the director of the Wound Care Strategy Programme, Una Adderley, said was that people who are put into compression very early do very well. And that's what we're aiming for. So we'll go on to the next part there. Charlie, was there anything else, sorry, in the chat that you wanted to talk about?
There was just one question from a lady. Let me just find it. The chronic limb-threatening ischemia, Janice, and how that concerns some people because they don't have the symptoms until you do the Doppler.
Yeah. So occult arterial disease does happen, and that's where it would be worrying that we are putting compression on at that low level, 20 millimeters of mercury, if someone has occult arterial disease, meaning they don't have symptoms. It is quite rare. I don't know, Lauren, did you want to talk about, are you experiencing, have you seen it a lot, or is it an occasional thing? I'll wait for Lauren to answer in that, because it should be an occasional thing that this happens, that people generally in their history or what you're seeing on the leg, when you do the test where you see how much blood returns, the test on the toe to see, can't remember the name of it, how quickly. No, just the actual test that you do to check blood flow back to the toe. We should get an indication from that and from the history of arterial disease. But Lauren, you are right, occasionally we do see occult arterial disease, and I guess it is just making sure that that person knows to phone you if there is any problem at all.
Janice, Lauren's just put in the chat, it's occasional, but she's seen it a few times and it's just something that sticks in the back of her mind.
Yeah, of course, because we have to be careful. And that's just being extra careful, extra vigilant. But for the majority of people with venous disease, with a history of venous disease, putting them into a low level of compression is where we should be aiming for to start that journey towards healing. So let's look at some things that might help you when you're thinking about your documentation, because at the end of the day, this session is about you making sure that our documentation is good, keeping our patients safe and keeping ourselves safe as well. And that's kind of what it's all about. And we know that wounds are complicated, particularly hard to heal wounds. And at Coloplast, we work a lot with nurses, tissue viability nurses in the whole, but we talked to lots of different nurses, and we said, how can we make this complicated thing break it down into simple steps to make it a wee bit easier. And this is what, working with the tissue viability nurses and then the people in the company, this was the approach which Coloplast have developed. And some of you will be familiar with it, but really it's about thinking about the 3 steps which are necessary to make sure you are covering all the essentials when we're looking at a hard to heal wound. And assessment is the most important thing. The holistic assessment of that person, which you're very good at, but make sure we take the time to do that properly. So we're doing a holistic assessment, which does take quite some time, but is absolutely essential. And then we're looking at the actual wound itself. So we're looking at the wound edge, the wound bed, the wound edge, and the peri-wound skin. So we've done our detailed assessment, we've looked at the wound, and we move on to preparation. So wound preparation is about removing the barriers to healing. So this is done either mechanically or by a dressing, but getting that wound to the best possible condition so that we can then move on to step 3, which is using the dressing and the treatment, which in this case for venous leg ulcer certainly is compression. So thinking about those 3 steps and just trying to break it down in that way may help when you're thinking what is best for this individual. And what the National Wound Care Strategy Programme recommend is that the surrounding skin is cleansed and debridement of the wound is considered if required. Now, you'll have different policies in different areas. I know that I work a lot in Scotland, and generally now we are suggesting that the wound is mechanically debrided leg ulcers at every visit. Now, that would be, or once a week. If you've seen the patient every day, you're not going to do that, but at least once a week that we are mechanically debriding the wound. But you look at your policy in your own area to see what they're saying. And again, from the National Wound Care Strategy Programme, the recommendation is that we apply a simple, low-adherent dressing with sufficient absorbency. So that's the guidance from the programme. And this is a person where those strategies were put into place. So this was a 90-year-old man who had no other comorbidities, but he had a leg ulcer. And the leg ulcer was mixed etiology, and he'd had it for more than 10 years. His ABPI was outside the normal parameters, so full compression wasn't going to be an option for this man. And he'd not been confident to travel since having the wound. So 10 years of an elderly person's life where they weren't able to do the normal things, which Sam alluded to, the huge impact a leg ulcer can have on an individual, and it had a massive impact on this man. So that was assessment. They assessed the wound and looked at what was needed for the wound bed, the wound edge, and the peri-wound skin. And what was needed was to remove non-viable tissue, to manage the exudate, to manage the bacterial burden, protect the healthy granulation and epithelializing tissue underneath, and to protect the surrounding skin. And here they used all-prep pad to prepare the wound, and then they used Biotin AG non-adhesive to treat the wound because there was a high bacterial burden there. And the results are here to see clinically in these pictures, but for more than 10 years, Mr. H had found wound preparation too painful to tolerate. But when they started to use all-prep pad, he could tolerate it, and the wound started to make progress. He was then able to tolerate a little bit of compression. It was only 10 millimeters of mercury, so 1 liner. But after day 3, he was able to get a liner on, which he couldn't have done before due to the pain. And after managing the infection and the exudate levels, his wound was then, dressing was changed to Biotin silicone and hosiery. And you can see in this picture from day 1 to day 53 when his wound was completely healed. And from day 1 to day 3, the difference in the wound bed in that very short period of time, but 54 days to heal a wound which had been there previously for 10 years, just by taking a step back and thinking, okay, what's best for this person? What can we do to move things forward? And that's what we all want at the end of the day, isn't it? To heal our patients' wounds. And we can just, think, sometimes we just have to take a step back and think, are we doing all the right things for this individual? And as part of the 3-step approach, this is a pathway. Now, you may have a different pathway, you may use this pathway, but again, if we're thinking, when we're thinking about a coroner's court and the fact that we don't ever want to be there, but keeping our documentation as the best it possibly can be, using a pathway helps that. Because we can say we use the venous leg ulcer pathway, and it may be that the person goes down, everything is fine, and they go into compression because there's no red flags, and they go into full, and this is based on the National Wound Care Strategy Programme as well. They go into full compression once they've had their detailed assessment, including ABPI, or they may go on the other side where they need further interventions. They need to be seen perhaps by the vascular team. But you can say we used the pathway and this is what we followed, and that will help with your documentation. And it helps you know that actually I'm doing the right thing because this is the national recommendation. And for some of these, they will have wound dressings on there as well, so that you know that, okay, I've done step 1, 2, and 3, and these are the choices that I've got. If the person's going into hosiery, these are the choices. If the person's going into compression bandages, these are the choices I've got. So this kind of pathway, whichever one you use, is really helpful in making sure that we've done everything just the way we should do. And again, that's the 3-step approach that is used in that pathway. So now we're going to have the actual coroner's court. So this is not based on a true story, but it's based on different things which have happened in clinical practice. So it will feel very real. The people who are the coroners and the lawyers and the nurses are all actors. But again, it is very similar to what you would see in a coroner's court. If you're in Scotland, this would be a sheriff court, but it's the same process. So we've got 4 videos to watch, and then at the end of each video, we'll have a poll, and you can give your opinion on what you've heard. And also we'll talk about, excuse me, some of the questions which might come up in your head during this when you're listening to it. And we'll use the chat for that. And if people want to talk, they can talk too. So let's have a wee look at Coroner's Court. This is the first video we're going to watch.
I am resuming the inquest this morning into the death of Elizabeth Mary Black, which was initially opened on the 27th of June 2021. It's my duty today to listen to the evidence requested in order to assist me in answering 4 questions: who the deceased was, and when, where, and how they came by their death. Who, when, and where are usually straightforward. It's how they came by their death I need help with. I confirm the deceased's full name was Elizabeth Mary Black. She was born on the 1st of January 1942 and died on the 14th of June 2021 whilst an inpatient at Spiral Down Hospital. In order for me to be able to issue a death certificate, I need to establish the circumstances surrounding Elizabeth's death. I will gather the evidence, and based upon that, I will then issue a death certificate. Depending on the evidence heard today, it may be that I cannot conclude death due to natural causes, in which case I will form a narrative version. Under Rule 42, no verdict shall be framed in such a way as to appear to determine any question of civil liability or criminal liability. That is for the courts to decide. Based on the witness statements I've received to date, I have decided not to have a jury for this case. I may have to reverse that decision should evidence come to light today that suggests a jury may be required. To assist me today, I have called upon witnesses. Elizabeth was 79 years old. She had a medical history which included hypertension, atrial fibrillation, type 2 diabetes mellitus, rheumatoid arthritis, and varicose veins. We've heard from the pathologist, who established the cause of death to be 1A, sepsis, 1B, cardiac failure, 2A, type 2 diabetes mellitus. The sequence of events started with a skin tear to Elizabeth's leg, which became infected, and sepsis then developed, requiring the limb to be amputated. Following this, further infection set in the surgical wound site, and Elizabeth never recovered from the surgery. We will hear from witnesses today to answer questions relating to the care and management of the wound in order to determine whether the wound sepsis leading to cardiac failure could have been prevented. Can I please call Ms. Brown to the stand? Can you please confirm your name and current employment?
My name is Ms. Brown and I'm the clinical manager at Boot Hill Nursing Home.
Were you involved in the care of Elizabeth, and in what capacity?
Yes, I was, as a community nurse at that time.
Can you explain to the court your experience and role?
I am a registered nurse and I had been working in the community for about 6 months, caring for Elizabeth. Prior to that, I had worked on the care of the elderly ward since qualifying last year.
What kind of things do you deal with as a community nurse?
We see patients who need injections, end-of-life care, pressure ulcer prevention and management, and lots of wound dressings.
Can you describe your involvement in the care of Elizabeth?
Elizabeth was referred to us by her GP to dress a wound to her left leg. She had caught her leg on a chair, which had caused a small skin tear. I saw Elizabeth the day after her doctor had visited and was concerned about a lot of leg swelling. The wound was quite small and I thought it would heal quite quickly, so I just applied a traditional adhesive dressing to her leg. That was on the Monday. I explained to her that everything should be all right for a few days and I would see her again on the Friday, as we were really busy that week.
What were your concerns about the swelling of her legs, and what did you do?
Well, I wasn't too concerned. I mean, her legs were swollen, but a lot of our patients have swollen legs, and Elizabeth had just been seen by her GP, but I did leave a message asking the GP to review her.
I understand Elizabeth was visited again earlier than planned. Can you explain what you found?
Well, I visited on the Thursday, as Elizabeth's son had rung our office and requested an urgent visit, and I was really shocked when I saw Elizabeth. Both her legs were now swollen and leaking, and her son had wrapped some towels around them. And when I took the adhesive dressing off, her skin came away with it, as her skin was so delicate. The wound was now much bigger, and her other leg was also leaking.
What did you do?
I called the team leader, as I wasn't sure what I could do, and she told me to use a soft silicone foam dressing and to bandage her legs from toe to knee in a wall bandage and a crepe bandage, and she could arrange an assessment.
What happened next?
Well, I was sent in to change Elizabeth's dressings regularly over the next few weeks, and I just continued with the silicone foam and the wall and the crepe bandage. I think for about 2 months or more, there wasn't much change. But but some days they were quite smelly with more leakage, and some days they just looked worse than others. We kept taking wound swabs, and she had been on a lot of antibiotics, but she often didn't take them as they gave her diarrhea. I don't think she was going to bed, and I don't really think she did what she was told.
What did you do to encourage Elizabeth to go to bed?
I couldn't really do anything, as I can't make her. But she said she could get comfortable enough in her armchair with her feet on a little stool, although sometimes this made her heels feel sore. Eventually, the team leader was able to visit, and she did a Doppler and put some compression bandages on Elizabeth. At first, I couldn't do this as I needed training. So there was a course which I attended, so I could carry on seeing Elizabeth to bandage her legs. I thought I'd developed a good relationship with Elizabeth, so I was pleased I could continue to see her.
How did you feel her wounds were progressing?
Well, the wounds were getting a lot better, but Elizabeth was non-concordant, and she kept trying to take the bandages off so she could get her shoes on, or pushing them down. On one occasion, a previous nurse had bandaged from further back on Elizabeth's foot, so there was no bandages around the forefoot. I did the same, but by then her foot was so swollen she couldn't get her shoes on anyway. And as the wound was nearly healed, I decided to leave the bandages off altogether. I thought this would give the wound a chance to dry up and to heal properly. And I just continued with the foam dressing as Elizabeth was really unhappy.
Did Elizabeth's legs deteriorate?
Yes, they did, and ever so quickly. I panicked and I called the tissue viability nurse myself. The TVN came out and checked Elizabeth's Dopplers again and agreed that she needed compression bandages. And she talked to Elizabeth for a long time about how to rest her legs properly and the importance of proper bed rest, but also plenty of exercise and good nutrition. And she started her in strong compression. I couldn't believe how quickly Elizabeth's legs started to improve again. Unfortunately, though, she developed another infection. And then this time she was admitted to hospital. And when she came home, her legs were open and leaking everywhere. The skin on her legs was raw. I don't know why they stopped using the bandages, so I just continued with the foam dressing, the woolen crepe. She also now had a pressure ulcer on her left heel, which she said she was admitted with, but I'm sure she never had any pressure ulcers when she went in. In the end, she was admitted again as she quickly developed another infection, but this time when she came home, she had her compression bandages on and she was on insulin.
Did her wounds start to heal again?
Well, at first they did, but then after about 2 weeks, I thought I could see a small bit of bone or tendon showing in the wound, but I wasn't sure. The wound was smelly again, and so I took another wound swab, even though one had been taken the week before. And I said that I would visit again in 2 days. The next day I spoke to the team leader who requested another visit from the tissue viability nurse.
Why did you not document that you could see bone or tendon in the wound in your records?
I wasn't sure what it was I could see. But when I went back, it was obviously tendon with about 10 centimetres showing. So I rang the doctor and the receptionist said she was unable to visit and she would ring me back. And when she rang back, she told me the doctor had prescribed antibiotics. But I was so worried, I went to see Dr. Porter myself. And when she eventually agreed to meet me and she saw the leg, she admitted Elizabeth straight away and she suspected sepsis.
Thank you. I have no further questions.
Okay, so a lot to think about there. I'm sure you've been writing notes on many, many things that that potentially went wrong in this case. But what I'd like you to do now is we will have a poll that's just coming up right now. Apologies, everything's on a bit of a go slow at the moment, but we'll get there.
Right, so I'm just sharing the results with you, Janice. So out of that poll, I think there's a few more answering, but it's looking like the majority are saying that Elizabeth wasn't concordant. So no, she wasn't concordant with that. Me personally, I think maybe were all avenues carried out for Betty? Was there a lot of conversation to inform Betty as to why she needed it? And actually her reasons were her footwear. So actually if we'd addressed the footwear, would she have been more concordant? Because that was the reason she was pushing it up. So again, it's having that discussion and having that dialogue with our patients and making sure that we've recorded that and the options that we're given. It's as clinicians, we need to work in partnership with our patients. It's not about sort of dictating what they need to have and compromising. Sometimes you do need to compromise, but if her issue was actually the shoes, could we have addressed that? And then she would have been able to manage to stay in the compression. I don't know what your thoughts are, Janice.
I think, no, I would agree, Sam. I think the treatment was changed so frequently. Did Betty or her family really understand what we were trying to achieve? It's not clear in that at all. So yeah, you need to have that person on board and they need to have the best understanding they possibly can of what we're trying to achieve, and that might have made a significant difference to the outcome actually. But it's interesting, it's food for thought, isn't it? But these are a couple of other questions, or several other questions that you might have thought about when you were listening to that first video. So I'm not going to read every single one of them out, but I'll just highlight a few, like what could have been done differently on first presentation of the wound. Is there guidance available on the treatment of skin tears of the lower leg? Do you have guidance in your area? We know that the International Skin Tear Advisory Panels say consider compression and use an appropriate non-adherent or low-tack dressing. So we should be starting compression on people with skin tears if they have no red flags. Treating it in a similar way to a leg ulcer, is that what's happening in your area? Did she need all those multiple antibiotic therapies? Was that appropriate or not? We've talked about concordance and non-concordance, and how can we improve communication? And then, do we require swabbing? And what could have been alternatives to swabbing this wound? So I'll give you all a bit of time to think, but I'm sure the answers are coming in. Charlie, is there anything from you wanted to talk about that you're seeing there?
So I'm just having a look. Sorry, it's me again.
Okay.
And there's some good comments coming through. So someone said about that the best practice statement on the management of lower limb skin tears in adults. So that, again, that's a really useful documentation document to use and refer to. Someone else has put, when will people stop using strips on skin tears? I absolutely feel your pain, because I am sure that when the people that apply 30 skin strips onto a skin tear, they've never had to actually be the person to take them off, because they're really can cause some further awful trauma to those wounds. Trying to remove them, and the pain that the patients feel, it's horrific. And I'm sure if they had to take them off, they would definitely not be putting them back on Especially we've got all these lovely advanced silicone dressings now. There's just no need to be using so what they call skin steri strips.
I'm here, Janice.
Good, Charlie. Good.
Yeah.
Enjoying it
So,
too.
yes. So there's also somebody's put about a discussion around patients' footwear and how they've declined footwear due to the appearances of them. So they often don't get any further forward, or they'll insist in squashing their bandaged feet into teeny tiny shoes. And absolutely, you know, patients can make unwise decisions. But what you need to make sure that you've done there is around your documentation, and document the conversations that you've had, the repeated conversations that you had, because it's no good just having that conversation once. We need to make sure we have those conversations time and time again with the patient to make sure they fully understand what it is that you're telling them and why they need to do what we're asking them to. But as I say, patients are allowed to make unwise decisions sometimes.
Yeah, absolutely. And it's not all on us, but as long as we're documenting the advice that we're given, and if it was declined and why it was. One of the things I would say about footwear, though, was remember that, again, the National Wound Care Strategy Programme are suggesting that we use something like a liner initially, up to 20 millimetres of mercury, so 2 liners, and then think of compression hosiery kits as first line. That will mean that people will be able to get their own shoes on, and it's more attractive to some people. Well, it would be to me, certainly. So, you know, that just to bear that in mind too, that bulky bandages are not, we're moving away from that very often now. Any other thoughts on?
There's some good questions, comments coming through again about continuing compression in the hospital, and I think because of the way that this story is going to be developing, we can have a bit more of a further discussion further on. But just something that I would like to pick up on is that, did she need multiple antibiotic therapy? Obviously, we are very aware of that antimicrobial resistance, and we all have to be managing and acting as antimicrobial stewardship to ensure that antibiotics are used appropriately. You know, we've seen some of the scary figures that are out there. By 2050, there'll be 10 million deaths due to antimicrobial resistance, and we all have a duty to really ensure that we're using antibiotics appropriately and optimising their effectiveness. So, you know, I think, you know, there is a discussion of actually the GP, without even seeing the wound, just prescribed antibiotics. Throughout my time working as a tissue viability nurse, I've seen many patients given antibiotics where it's not necessary. Red legs, having repeated antibiotic therapy, it's just not appropriate, and we need to be challenging that and having that confidence and knowledge to be able to challenge back when it's not needed. Obviously, when it is needed, absolutely, we need to get them quickly, because that patient is very at risk of developing further systemic infection. But yeah, I think we all have a duty to be aware and ensure that they're used appropriately.
That kind of goes back to our 90-year-old man, doesn't it, who had a sloughy wound. Now, you could go down the route of thinking antibiotics might help, but actually wound debridement was all that was needed. So mechanical debridement of that wound, and then addressing with, in this case, it's silver in it, but addressing with an antiseptic, and it was a better route to go down for him, and it did lead to healing than repeated use of antibiotics. So very important. Thanks for that, Sam. Charlie, any more from you, or shall we carry on with the next one?
There's just somebody asking about mental capacity assessments in the the community and who can do those, and there's quite a few people that have advised that the community nurses are able to complete mental capacity assessments.
Okay, thanks for that, Charlie. Okay, so we will move on, and we're now going to look at questioning from a lawyer in this case.
I now invite Mrs. Smith, representing Community Services, if she has any questions.
Thank you. Yes, I do. Am I correct in thinking that the community nursing team you were working in was under a lot of pressure at this time due to sickness and the taking over of another patch?
Yes, it was terrible. I was missing my lunch breaks and working late every day. There's only so much you can do with 20 or more visits a day.
Did you keep measurements of the wound and report them to your team leader?
Yes, as much as possible, but I knew how busy the team leader was, and she didn't always have the time to listen to me.
Would you say that you had developed a good relationship with Elizabeth?
Oh yes, but she could be quite naughty and non-concordant at times. But we mainly had a laugh about it.
No further questions, Your Honour.
Ms. Best, representing Dr. Porter, the general practitioner, do you have any questions?
Yes, thank you. I notice you took several wound swabs. Did you ever discuss these with the doctor?
Not directly, but I rang and spoke to the receptionist.
Why is it that I cannot see any evidence of this? Did you record it anywhere?
No, I expected the receptionist would record this information in her records.
Did you not consider it important to record your conversation?
Well, not really, as the doctor wouldn't see it in our records, would she?
No further questions for this witness, sir.
Thank you, Ms. Brown. You can stand down. I'd like to call to the stand our second witness, Dr. Porter. Can you please confirm your name and current employment?
My name is Dr. Porter and I'm the lead GP at the Sunnyside Surgery.
Were you Elizabeth's named GP?
Yes.
How many times did you see Elizabeth between November 2020 and June 2021?
Twice. Once when she first injured her leg, and then again in June when the community nurse alerted me to the deterioration and I had Elizabeth admitted to hospital. She was also seen earlier in the year by the practice nurse for disease monitoring.
Would you say it was normal for a GP not to visit more frequently for someone with a wound of this nature?
Yes, I would say that's normal. I would expect the nurse to take the lead in wound management.
Would you have been aware of the risks and the deterioration of the wound?
As I said, I would expect the nurse to keep me updated if there are any problems.
Clearly, the nurses tried to contact you.
Please don't interrupt the court. You'll get your chance to ask questions later. How did you manage the results of the wound swab?
I would have only acted on the results if the nurse had contacted me.
Did you know that the nurse contacted you after the swab was taken at the beginning of June when she was concerned that the wound was swelling?
I can't answer that question. I have no details of that conversation, so I have no evidence that it ever took place.
How did you communicate your concerns to the hospital staff when you arranged admission for Elizabeth?
I had a telephone discussion with the on-call vascular team.
And was it your impression that Elizabeth would be admitted straight to the vascular ward?
I presumed, possibly. Well, I suppose I couldn't be sure, as I don't know how this would be dealt with in acute.
Thank you. I have no further questions. Ms. Best, any questions?
I don't have any questions.
Mrs. Smith, do you have any questions?
Yes, I do. Dr. Porter, why did you not visit when the nurse first rang you?
Well, I would have been in surgery at the time. I said I would prescribe antibiotics, and I did speak with the nurse as she was very insistent. And I did actually visit at the end of my surgery.
Is it common that there is a failure to record telephone conversations?
I can only presume that the receptionist was too busy to record all calls, but she was adamant that no one called about Elizabeth.
Do you think that you might start getting the reception staff to record all telephone conversations?
I object to this line of questioning, sir.
I agree. Please move on, Mrs. Smith.
What did you think when you saw the wound?
I was very concerned and I arranged for urgent hospital admission.
Why did you not write a letter to go with the patient?
I had discussed Elizabeth on the telephone with the on-call vascular team. I didn't think a letter was necessary. I had very little time and I expected the wound to be looked at straight away.
I have no further questions for this witness.
Thank you, Dr. Porter. You can stand down.
Okay, so can you read the poll out for us, Sam, and see what people.
Yeah, so the next poll should all be coming up onto your screen. So it is, when is a swab indicated? So your three choices are: if the wound is not progressing, if the wound is locally infected, or unsure. And they're just getting logged at the minute, so I'll just give a couple more seconds just to allow people time to submit their answers. It's looking like the resounding response is at 76% is if the wound is locally infected, as opposed to if it's not progressing or unsure. There's 2% that were unsure, and 77% that said if the wound's locally infected.
Thank you. Yeah, and I would agree with that. I'm sure Sam would too. Wound infection is a clinical diagnosis. So what we see in the wound, a wound would be red, hot, painful. There would be an increased level of exudate and more odour. That's the classic signs of infection. So you have clinically diagnosed that. You swab to make sure that the antibiotics which you'll be starting anyway are the correct antibiotics. So that's the reason we do a swab. A wound which is deteriorating, it might be that the doctor suggests we take a swab for that reason, but that's not particularly a reason to take a swab. So it really is very clearly what you're seeing and what you're smelling and what that person's telling you, which will indicate whether or not to take a swab. But you all know that because that's what you've answered. So well done, everyone. So let's look at this second set of questions around about the last short film that we watched. So we saw there that the solicitors were interviewing both the nurse and the GP. So these are some of the questions you would be thinking about. Why did the solicitor representing the community nurse ask the questions she did? And then as well, the solicitor representing the GP, why did she ask the questions that she did? Workforce, a question around that. How does this impact in the priority of care of patients and handover to senior colleagues? So does that impact in your area? It will, and what impact does it have? She was seen by a practice nurse for disease monitoring. What could have been done at this review to possibly prevent and change the pathway for this lady? So think back to Betty's story and how things went when things went well. What could have been done differently for this lady? And do you document all contacts with professionals, patients, family members, and what are the outcomes if that's not documented? So are we documenting all of these things, which essentially we should be? So if you want to put your responses in the chat, and if anyone wants to speak, just put your hand up and we're happy for you to do that as well. And I'll come to you again, Charlie, just to start with. Is there what's coming up in the discussion?
We haven't had anything from the group discussion slide that you're sharing at the moment, Janice. There was was just
a wee bit early.
Yeah, just waiting for people.
Yeah.
There was quite a good discussion, just saying that it would have been good to have had a option of depends in regards to that wound swab, and because as a when you have good skills and knowledge, at some point you can think, well, I'm just going to manage that with an antimicrobial and monitor it closely, and actually is a wound swab actually needed at that point? So again, it's following your local policies as well.
Yeah, absolutely.
What you're actually guided in within your trusts or areas that you work, or if you're in the private sector, what your guidelines actually tell you. But yeah, I in some cases you may not need to do it if you've got those really subtle signs of local infection. maybe not so much with the classics, but those subtle signs, and you can apply an antimicrobial and review quite quickly and see that actually that's been really beneficial. Yeah,
and I guess conversely, if someone's having surgery for another reason, they may swab the wound just because that person's having surgery. So there are the outliers, if you like, and then there's the very kind of definite, this is what a wound infection looks like and we must swab.
Yeah, so some of the comments. Sorry, Charlie.
I was just going to say there's some comments around the responsibility of both parties to document contact with each other. It shouldn't fall on one or the other to make sure that that's documented. So if the doctor calls the nurse, the doctor should be documented that, but so should the nurse as well. And there's some people asking about pictures, whether any pictures of these wounds had been taken, talking about workforce pressures on the teams. And again, about both parties documenting. Some people saying they don't document phone calls, but follow with an email to clarify the main points. And around saying that they haven't got enough time is not good enough. And absolutely, as Sam said earlier, around documentation, it is a necessity. It's not an added extra. And so we must make sure that we make time to do our documentation, because that will not stand up in coroner's court that you didn't have time to do it.
And it is again about thinking about safety for that person, but protecting yourself as well. And that's what all this is about. So documentation is so important for all of that.
There's another question. Sorry.
Sorry, on you go.
Just around whether the hospital staff would be questioned. They should be questioned too. And absolutely, anybody that's been involved with this patient's care would be called as a witness in the coroner's court, depending on how far back they wanted to look into this patient's care.
And whoever wrote that, you've just preempted the next bit, because yes, we do have an interview with the hospital people too. Okay, and I know, Charlie, you're leaving us now. I know you have to go to another meeting, so thank you so much for helping with this. And if we're finished with that discussion, I think we'll move on to the next video. Okay.
I'd like now to call Ms. White to the stand. Please confirm your name and current employment.
Yes, I am Miss White, and I'm the Advanced Nurse Practitioner in the Accident and Emergency Department.
How long was Elizabeth in your department?
She was prioritised as per our targets of admission within 4 hours.
And what treatment did Elizabeth receive?
She had been started on intravenous antibiotics, as I was sure she had an infection.
Where was the infection?
It was unclear initially, but we now know it was in her leg.
Am I correct in understanding that the bandages were not removed from Elizabeth's leg whilst she was in the Accident and Emergency Department?
Yes, that's correct.
Is that usual practice?
We have very few bandages in the department. We see lots of patients coming in with bandages on their legs and often compression, and we don't have any compression bandages. If we did, the nursing teams are not trained to apply them.
Would you always remove bandages now?
Oh yes, straight away. We have a good supply of dressings and bandages now, and pathways in place for any patients who come in with leg ulcers.
How did Elizabeth seem to you?
Not very well. She had tachycardia and raised blood pressure. Bloods were requested and inflammatory markers were very high, as were her blood sugars. She was showing signs of infection.
So why did you not remove the bandage on her leg to check the wound for infection?
Well, I actually suspected a chest infection, and I did start her on intravenous antibiotics. I did not realise she had an ulcer. No one had told me, and it was a very busy day in the department.
Was the vascular consultant called to see Elizabeth?
No, I arranged for Elizabeth to be admitted to the medical ward.
Were you aware that Elizabeth's GP had spoken to the on-call vascular registrar?
No, I was not made aware of that call.
Thank you. I have no further questions. Mrs. Smith, any questions for this witness?
No, sir. I do not have any questions for this witness.
Ms. Best, do you have any questions for this witness?
Yes, if I may. What I cannot understand is how this lady came through the accident and emergency department without anyone looking at her wound. Could you shed any light on this?
We are not wound care experts and have little experience of treating ulcers in A&E, but we have since had some training on wounds and leg ulcers from our tissue viability team.
Perhaps you may make more of an effort next time.
Please think carefully about your line of questioning. This is not helpful to the court. Do you have any further questions?
I apologise. I have no further questions for this witness.
Thank you. Thank you, Miss White. You can stand down.
Again, onto another poll. So Sam, could you read the poll out for us?
Yeah, so the next poll is removing compression and stopping this therapy harm? And it's a yes, no. Just give a couple more seconds for people to respond. It's looking quite even. A minute. So we're at 41% yes, 42% yes, 47 or 58% no. This keeps changing on me. It's all slowing down now. So it's around 42% are saying yes and 57% are saying no. And I think this is to do with how you are reading this question, because obviously she's entered the A&E department and actually she needed this compression taken down for them to do a true assessment. So you by stopping the compression is actually, you need to prioritise what your needs are for that patient. So yes, you need to take the compression off to be able to do that full assessment, but obviously leaving that compression off for the rest of her stay within the acute setting, if compression therapy is needed, then you know you're taking away a component of her therapy, her disease, her venous disease, and she does need that compression. And actually, by removing it and not being able to provide that, you're not giving that gold standard best care. So it is a bit of a discussion maker, I think, is what you could call it, because for me, both answers work. What do you think, Janice?
Yeah, absolutely. I would totally agree. In the case of Elizabeth, it was essential that they should have taken the bandages off, and that may have made a big difference to the outcome. It might not have ended up with a coroner's court, but equally, yes, I know the frustration that people in the community have when a person goes into hospital, their compression is taken off and there's no other compression put on, and that is a big. It doesn't happen everywhere, but it does happen, and it is something. It's a big educational need, isn't it? When nurses in hospital need to have the confidence and competence to apply compression, and I do think with the National Wound Care Strategy Programme and the fact that they are saying we can put mild compression onto people, that we might see a change in that practice and a change for the better. But yeah, it is a very debatable point, isn't it? So these are the discussions. One of the other things I wanted to point out about that one, when the nurse practitioner mentioned that they are now trained in A&E, that was them preempting a regulation 28. So they were saying they had made these changes so that they didn't have that. So you might have picked up on that one. But these are some of the things that we would think are worth discussing around about that last video. So what was the impact of the GP not sending a letter with the person with Elizabeth when she went to the emergency department? And why do you think the dressings were not removed in A&E? And what could be done to change this practice? And I think that was preempted in the discussion. And how can a tissue viability nurse assist the A&E department to give the staff the confidence in wound care? Sam, you'll be able to answer that one, I'm sure. And who's responsible? Responsibility is it to remove the dressings and assess the leg? Is it the nurses? Is it a healthcare assistants, or is it the doctors? So we'll leave that with you and see what your responses are.
So some of the responses coming through are because the GP didn't send that letter, it didn't make it to the A&E staff, they didn't know the full reason for that admission, and that they needed to see the vascular. So again, it's all coming down to that communication between different specialties, and why communication is so vital, to make sure that everyone is on the same page. We do another one of these on pressure ulcers, and the discharge letter never goes home with the patient that's discharged into a nursing home. And again, it's really the crux of where everything falls down, is that lack of communication. Someone's put GP sending a letter to ED. What's that? So it is hard to get that communication and get it working really fluidly. As we know, in the NHS, all systems don't talk to each other. It'd be so nice if we just had one system that everything communicated within. And the fact that we're still sending paper letters of discharges with patients, when we are, you've got a phone that can switch your lights and put your heating on and clean your fridge, but yet we can't get a patient to go into another service and get that communication working every time. But hopefully it will get better. Quite a lot of comments as well about compression in hospital, and like you said, Janice, with the National Wound Care Strategy recommendations, there is more of a need for it to be happening. With the Legs Matter campaign last year, obviously the theme around that was harm, and actually we should be challenging, and if patients are having their therapy removed, we should be challenging and questioning why that's happening, because that is harm at the end of the day. If they're not receiving what they need to help that disease, you wouldn't not give a diabetic insulin because they need that insulin. So why do we feel like with legs, and it is a confidence and a skills and whose responsibility it is. It is a big subject to cover, but I think it will start getting better because we will start acting on it and actually referring to it as harm. Just saying it's bad practice that the dressings weren't removed in A&E. Somebody who's actually worked a long time in A&E said that they would always do a sort of a top to toe skin assessment. So that's really good that would never happen in their area. And just to reiterate, this is a fictitious story. Obviously it's showing where things go wrong, so it's not to sort of do that blame, and so we're blaming everybody. It's just to show how these things can happen. And I know for me, I can relate to lots of things that I see throughout these videos. It just gives you that thought process of what you can do to make it better. Just going through them, sorry. Fear of compression bandages. So again, you know, if I take it down, I can't put it back on, what do I do? Giving that delayed care and treatment. Having a joined up system would be a dream, wouldn't it just? And it's just having the right clinician at the right time to give that right care. Someone else has said, why does this always fall to the TBNs? Wound care should be part of pre-reg education. Absolutely, but I think what I've found, so I've been a TBN working in both acute and community services, and actually it's ensuring that clinicians keep their competencies and skills up to date. But I think, you know, the introduction of hosiery and liners is a really good way of ensuring that compression is achieved without the skilled knowledge in bandaging. So there's so many comments coming through. Full assessment wasn't done. Just again saying about that lack of confidence and experience in wound care. And also the wrap garments, yes, they're another really good system that can be utilised. So really good comments. Well done, everyone. It's good. That's fantastic. Yeah, you're obviously really getting into this, and it's so important. And I think when, like Sam says, people do think compression bandaging is complicated. It's not if you know what you're doing, but it's people get anxious about it. But now we've got other alternatives. We've got wraps, we've got compression hosiery kits, we've got liners. So making that transition to hospital should be a lot easier too. So thank you for that. That was really good discussion. So we're on to our last video now, and I'll just play this for you, and then we'll have our final discussion.
Can I call Nurse Spears to the stand? Can you confirm your name and current employment?
I'm Miss Spears. I'm a registered nurse, but I've moved from the medical assessment unit and I'm now on the rehab ward.
Were you involved in looking after Elizabeth?
Yes, I was.
Am I correct in thinking that the bandages were left on her leg for a further 4 whole days before being removed?
Yes, that was normal practice when patients had been admitted from community. We usually find out when the bandages were due to be changed and change them on that day.
How did you know when Elizabeth's bandages had been changed?
Elizabeth told me. She was quite good at communicating. She did ask for them to be changed, but I said no because it was important we didn't disturb them.
How was Elizabeth being treated?
She was needing a lot of help to do things, and we were trying to encourage her to eat. And she was having intravenous antibiotics, and her MUST score was improving a little.
What happened when the bandages were removed?
I was horrified. Her leg looked like it was rotting. I'd never seen anything like it. So I called the doctor, who called the vascular consultant, and she was moved to the vascular unit. And I understand she had an amputation the next day. She was very poorly after surgery and had an infection in the stump wound. She was on critical care, and I believe she died 2 weeks after surgery.
Thank you. Mrs. Smith, any questions?
Yes, thank you.
Miss Spears, would you always ring the community nurses to discuss the bandaging?
Not really. I'm not sure we need to. We are the people looking after her in hospital.
You told the court that you would ask the community nurse when the bandages needed changing, but it would appear that on this occasion you did not do so. Why was that?
Well, Elizabeth could tell me when the bandages were changed, which was on the day she was admitted, so I thought they'd be all right for a few days.
What if Elizabeth couldn't communicate with you?
Elizabeth's son also says she had her bandages changed when she came in.
No further questions, sir.
Ms. Best, any questions?
Yes. Miss Spears, if a person is admitted to hospital with a wound, surely as part of their care, you should assess the wound.
I suppose you could say that.
Are you agreeing with me then?
Well, yes and no. I can see your point, but hospital policy is to leave bandages in place until discussed with the community nurse managing the care.
Was the management plan discussed with the community nurse?
I'm not 100% sure. I didn't talk to them, so I don't know if anyone contacted them.
There is no evidence that the ward staff contacted the community nurses at all.
Thank you, Mrs. Smith. Can I remind you not to interrupt, and then perhaps this expert witness can answer the question.
Was there any documentation in her records?
I'm not sure. I'd have to consult the records.
Well, go ahead then.
No, I cannot find anything about the community nurses.
No further questions, sir.
Thank you. Thank you, Nurse Spears. You can stand down.
Sorry about that. So here is our poll again. So Sam,
Yeah.
read it out.
So this poll is, whose responsibility was it to care for the wound whilst the patient was in the acute care setting? So you've got 4 choices here. So was it the acute care nurse, the community nurse, the GP, or the ward doctor? There's quite a resounding one answer being given so far. So we're at 100% with the acute care nurse. Oh no, we've just got a ward doctor selected now. Seconds. So 94% have said it's the acute care nurse's responsibility to ensure that wound is cared in the acute care setting. Yeah.
Okay. Okay, so yeah, you could argue that the doctor would also have been part of that. There wasn't any very clear guidance on who should be looking after the wound, and that's as a result of that, things were done incorrectly. I also thought in the video, listening to the nurse who said when she took all the bandages off, she'd never seen anything like it. The leg looked as if it was rotting. To me, that leg would be there would be a lot of exudate and there would be a lot of odour. So did that not alert them to the fact that this needed treatment much more quickly? No, just a thought. But for the final discussion then, in addition to infection, is there anything else that may have contributed to her surgical wounds breaking down post-operatively? So have a think about that. And why might the ward staff not have contacted the community nurses as per policy? It was their policy to contact them and they didn't do that. Why was that? What policies are in place to guide clinicians to remove bandages in between services and wards? Do you have policies in your area? And that'd be interesting for you to let us know in the chat. And do you see this in practice? And what can be done to change people's confidence in leg ulcer management? Okay, and I'll give you a minute or two to think about that and hear what your thoughts are.
So some of the things coming through now is why the wound may have broken down, her diabetes, it could be lots of contributing factors, but I think just due to the extent of that infection that was present there, and if they, you know, if anything had been left behind following that surgical intervention, then it's not gonna heal, is it? Lots of comments about the photos and taking photos, poor nutrition, existing infection post-op, nobody taking responsibility and thinking everyone else will do it, relying on the patient whose account would not always be accurate. So yeah, so talking to the patient, saying when your dressing's due as opposed to actually doing it. And also, you know, as part of our risk assessments, one of the risk assessments is doing a full skin check. The fact she was in hospital for 4 days then means that all those risk assessments for pressure ulcer prevention would also be null and void, because they either haven't done it or they haven't completed those risk assessments. And again, it's just highlighting the need for good documentation, delayed correct care and treatment, poor communication, and documentation. So hopefully that will all help you think of how you don't want to be practicing out there, and making sure that we're doing things appropriately. Someone's put, I completed a tissue viability 2-day leg ulcer training day, which I found helpful and increased my confidence a lot. So again, it's that confidence that maybe ward staff don't have because they're not exposed to these dressings regularly, and not having that confidence. But then, you know, like we said on the earlier session, it's about escalating and getting the appropriate specialist if you don't have those skills yourself, not just sort of ignoring it and hoping that it will go away, because that's not going to provide you any evidence or give you a good rationale for the care you provided for that patient.
Yeah, definitely. And on the question of photography, we know that all pressure ulcers should be photographed. It will depend on your area, but a leg ulcer isn't necessarily, there isn't that guidance on all leg ulcers should be photographed. But you would assume as that wound started to deteriorate, there would be some photography, and it isn't mentioned at all. So that means if it isn't mentioned, it hasn't been done. So that's another thing one that you brought up in several of the chats there, and it's really important because it is a very clear marker. We can look at that and see, is this one getting better? Is this one deteriorating? What do we need to do? So thank you again for all. Yeah, we're just well, I'm just going to say it's sorry, Sam. You are now the coroner. Okay, this is your decision. So it's over to you what the conclusion of this is. So we're going to go into this final poll, as Sam mentioned. Sorry for preempting that, Sam. But here we are. Here's your final poll, and you can decide on what the conclusion to this is. You're the coroner.
Wait a few more seconds. There's still quite a few going through.
Not easy, is it?
Starting to slow down a bit now. So the highest percent is actually on neglect. So there's 1% that's natural causes, 4% accidental death or misadventure, 1% unlawful killing, suicide 0, neglect 85%, and narrative 8%. Okay. So that's what's come through. Yeah.
Okay. So yeah, just as a reminder, these are all of those facts and findings and verdicts. And actually, in this case, it was narrative. So for the 8% who said that, well done. So it was a set of circumstances of the death in detail, based on the evidence that's heard, and that would be considered a narrative verdict. So yeah, but it's quite challenging. I'm glad I'm not a coroner, put it that way. But yeah, looking at all of these, there are ones I can see why people have said the different things that they have, but in this case it is a narrative. So Regulation 28, remember I mentioned this. Would there be a Regulation 28 administered in this case? That is, as Sam pointed out, where the coroner will say that these are the changes that you have to make within 56 days of receiving this Regulation 28 to ensure that this doesn't happen again, that there aren't further avoidable deaths. But they had preempted it when they said, you know, in A&E they now have that training, they remove all bandages, all dressings, and they can apply compression. So yes, there may have been other things in the Regulation 28, but that was the particular one in this case which they had preempted. And that's us, folks. Thank you so much for joining us. Thank you for all your brilliant comments and questions and thoughts to each other. Even I know you were helping each other out in this, which is absolutely brilliant. If you can either scan the QR code that you see on the page, or use the link at the bottom, so the link to Coloplast, to give us your feedback on what you thought of this, anything we could improve, any other events you would like to have in the future, and we'll leave that one with you. And just thank you so much for joining us for the last couple of hours, and I hope it's been helpful too. Thank you. Sam, anything more from you?
No, just thank you very much for your contributions, because it really does. It's your comments and that brings sort of this alive. And every time you get different comments, so it's really good. And seeing that you've all sort of picked up on different aspects throughout the session. So brilliant. Thank you, everybody.
Thank you.